Acute neck masses. Neck masses that appear over a short period are generally symptomatic. Blunt or sharp trauma may damage tissue and vasculature, creating a hematoma. Small hematomas are typically self-limited, but large, rapidly expanding hematomas require immediate intervention and possible surgical exploration. Similar mechanisms of trauma, plus the addition of shearing forces, potentiate the formation of pseudoaneurysms or arteriovenous fistulas characterized by soft, pulsatile masses with a thrill or bruit. Computed tomography, CT, angiography delineates the extent of any possible vascular injury, and treatment is usually surgical ligation. 1. By far, the most common cause of cervical lymphadenopathy is infection or inflammation created by an array of odontogenic, salivary, viral, and bacterial etiologies. These lymph nodes are often swollen, tender, and mobile, and can be erythematous and warm. Upper respiratory symptoms caused by common viruses usually last for 1 to 2 weeks, whereas lymphadenopathy generally subsides within 3 to 6 weeks after symptom resolution. 2 Although unknown viruses cause 20% to 30% of upper respiratory infections, which occur an average of 2 to 4 times per year in adults, more common viral pathogens include rhinoviruses, coronaviruses, and influenza. 3,4 Biopsy is appropriate if an abnormal node has not resolved after 4 to 6 weeks, and should be performed promptly in patients with other findings suggestive of malignancy, such as night sweats, fever, weight loss, or a rapidly growing mass. 5 Certain infectious etiologies, human immunodeficiency virus, HIV, Epstein-Barr virus, cytomegalovirus, toxoplasmosis, tend to cause generalized lymphadenopathy, which emphasizes the need for a comprehensive lymph node evaluation. 1. Bacterial infections of the head and neck predominantly cause cervical lymphadenopathy. Lymphadenopathy caused by Staphylococcus aureus or group A beta streptococcus has no predictable sites of lymph node inflammation. Disseminated Epstein-Barr virus or HIV infection often involves the cervical chain. 2 Common antibiotics used for lymphadenopathy include first-generation cephalosporins, amoxicillin, clavulanate, augmentin, or clindamycin. Bartonella henselae infection causes mobile, fluctuant, erythematous, and tender, but characteristically isolated, lymph nodes similar to lymphadenopathy caused by staphylococcal and streptococcal infections. Cat scratch disease develops when a kitten or flea transmits B. henselae, producing a regional lymphadenopathy, usually near the site of inoculation. 1, 2. The extrapulmonary form of Mycobacterium tuberculosis infection causes a cervical lymphadenopathy. The diffuse, bilateral lymph nodes are characteristically multiple, fixed, firm, non-tender masses located in the posterior triangle, cervical chain. 1 Suspicion should be high in those who have recently immigrated from or traveled to tuberculosis endemic areas such as India, Southeast Asia, or Sub-Saharan Africa, and purified protein derivative testing should be performed in these patients. A negative result on purified protein derivative testing does not rule out atypical mycobacterial infections, which also should be considered. A fine needle aspiration biopsy, FNAB, of the lymph nodes or referral to a head and neck surgeon may be warranted if the lymphadenopathy persists after initial diagnosis and treatment. Inflammation of salivary glands, acute sialadenitis, commonly occurs in older, debilitated persons in the setting of dehydration or recent dental procedures. 1 Affected salivary glands cause rapid or gradual onset of pain and swelling, possibly with local edema, erythema, and tenderness or fluctuance consistent with an abscess. Bimanual compression toward the duct opening may expel purulent discharge into the oral cavity. Neck CT with intravenous contrast media may be warranted to confirm this diagnosis and rule out other contributing etiologies such as a dental abscess or local tumor compression. 1